Welcome to Health IQ. I'm Dr. Alan Siegel. Today we have two very special guests, Doctors Kristin Roye and Dr. Benjamin Roye. Dr. Kristin Roye is with Briarcliff Pediatrics, and Dr. Benjamin Roye is with Columbia Children's Hospital. Welcome, doctors.
Thank you.
How are you?
Thanks for having us.
So today's a special event because we have two doctors, husband and wife, in the pediatric specialty fields. And although your days look very different, I would imagine, from a pediatric perspective. So you being a general pediatrician,
Yep.
and you doing orthopedics. How'd you both, or one of you, decide to get into pediatrics? I know there's a little history here. So.
There is, yeah. No, there's definitely a pretty strong family history of pediatric care in my family. I'm partners with my dad, which is great. He's also does pediatric orthopedics. My mom's a pediatric nurse practitioner, and I have multiple other sort of pediatric nurses, especially on my dad's side of the family as well. And I've always, oldest of 6 kids, always been around kids, growing up and throughout life. And I always knew, even from the first day of med school, that I wanted to take care of kids.
So that's great. That's an inherent process for you. And how about you, Dr. Kristin?
I'm actually the first doctor in my family.
Okay, great.
But I grew up with a mom who taught kindergarten and first grade for 34 years. Okay. So kind of working with kids seemed to be very natural. Always knew I wanted to be a doctor, and pediatrics was always just the first thing I thought of.
That's great. And you guys, you have families of your own, so working with other people's families, I know it's a different perspective. So what are you seeing in your general peds practice in terms of like healthcare trends, or what are parents like most concerned about with their kids these days?
Lots of different issues that come up with pediatrics. We span the gamut from newborns all the way up to age 22.
Yes.
So with that age span, you're going to get lots of different topics depending on the age
Sure.
the kids are.
Bigger kids, bigger problems, right?
Absolutely.
Yeah,
absolutely.
Little kids, little problems too, but different types of problems.
Absolutely,
But,
it's all a spectrum. But initially when the kids are young, the babies, parents initially, they just need help as far as just parenting. Kids don't come with instructions when they're born.
Right.
So immunizations are always a hot topic, a very important topic, and of course, we believe that immunizations are the best protection you can give your child when they're starting out. And then we run the gamut through school age with even just, kind of sports-related issues. We get up into adolescence with a lot of social and emotional issues with kids, including the sports that kind of go along the way. And then we transition into young adulthood.
Yeah, so you really do take them from birth all the way to being young adults, and you get to see them grow up and work through that process with the parents and the kids, and you build strong relationships, right?
Absolutely. That's what's fun about pediatrics. It's in general a happy specialty,
right.
And the nice thing is you do get to be part of their their growth and development, which is a huge honor.
Yeah. Now, as an orthopedic, you see sometimes some things that from childbirth or deformities or other types of issues that are maybe more severe when kids are younger, and sometimes from a general pediatrician to your specialty, things like hip dysplasias and other spina bifida, other issues. So more serious issues sometimes.
Sure, right. It also varies, because as I only see kids, so I'll see up to 18 or 19 in general, something along those lines. And what I'll see in a day varies dramatically. From the very young child with a very severe scoliosis or other spinal deformity, which is a real significant issue, or children that have very devastating neuromuscular diseases, spinal muscular atrophy or other things like that, to the basically 4-year-old child whose mom's concerned because their child looks like they have knocked knees.
Right.
So I see a fair bit of that in my practice, which is nice, because it'd be, I think, difficult if you were only seeing very medically complex patients all day long.
Right, and then developmentally, there's crossover from both the specialties, where you have growing diseases, things like Osgood-Schlatter's and Sever's disease, and things where things are coming into your office, and you may have to send it out for orthopedic specialty, but developmental things that don't happen right away, but over time you start to see things develop in the kids as they're getting older, growing too fast, things like that, repetitive, so that happens a lot.
Yeah.
Are you guys seeing trends in repetitive stress injuries with kids playing a lot of sports at young ages?
I mean, I certainly am. I mean, obviously I see lots of different types of sports injuries, and see lots of stress fractures, stress reactions, things like that. And it's something which, I've been in practice for about 12 years, and so it's hard to compare maybe to what I've been seeing, because I wasn't seeing it, 20 or 30 years ago, but certainly, from my experience as an athlete growing up, and even just what I've seen over the past, decade, There's been so much more specialization and less time off, and instead of kids being 3 and 4 sport athletes, they're 1 sport athletes, maybe 2 sport athletes. So they're doing the same thing, those same repetitive types of activities, day in and day out. And I'm definitely seeing, not a week goes by that I'm not seeing a stress fracture, whether it's a stress fracture in the lower back, which is very common in kids, the tibia, the foot, and the hip, all kinds of places. And it's it's difficult. It's one of the more difficult diagnoses that I actually have to give and deal with because, as you might imagine, the kids that develop these injuries are really intense. They tend to be really into their sports. They enjoy doing it a lot. And
the parents are intense too, right?
So it's not just definitely be intense.
So you probably have to manage a lot of these cases from a chronic standpoint, and dancers, young ladies that are dancing, and gentlemen, but young girls, a lot of fractures and injuries, and sometimes nutrition and the way they eat and the way they, so you have to manage cases like that. I'm sure you see a lot of, not malnutrition, but maybe girls just not doing the right thing to feed their bodies, get them as strong as possible, and they're dancing more than some kids play soccer and lacrosse combined. I mean, they're hours after hours, so you see a lot of those types of injuries with those patients.
We have something called the female athlete triad, which is really quite common, often not recognized because it's actually very easy for maybe a child to mask it in certain ways, but generally they tend to be female athletes who excessive exercise, disordered eating, not necessarily an eating disorder, but a little disordered. They're they're really counting their calories. They're watching what they're eating, maybe a little bit too much. And that can affect a lot of things, including their menstruation and just kind of their overall health. So it's something that we have to look out for.
And bone strength, potentially, if they're not getting the right types of foods.
Absolutely. They're dysmenorrheic, they're not having the regular periods, their estrogen levels aren't normal, and that directly affects their bone health. And it's a double jeopardy because they're at risk because of their increased activity as well as their decreased bone quality. So those two things together really put them at increased risk for stress injuries.
Right. And now we're talking about nutrition. As a pediatrician, nutrition is, I think, a big important part of kids' development and how they grow up, and socioeconomics and things aside, you can have various obesity problems at a young age. What do you think? As professionals, we should be doing more, or is education? What can we do with the parents and the communities?
Well, honestly, it starts at the very beginning, and as pediatricians, we're kind of on the front line with that, and it really does start with infancy, whether or not you're breastfeeding or bottle feeding, learning and understanding how to properly feed your child and what are healthy habits that you want to model for your kids. Because really a lot of what kids do is kind of based on what they have at home and what their parents are modeling.
Cultural stuff, sometimes cultural, sometimes it's geographic, and there's a lot of variations to what goes into the nutrition. So trying to just re-educate them and give them information on that, so that's important.
Right.
I was going to say, I really think that it's incredibly important, and we have seminars and meetings in orthopedics about the impact of obesity, from an orthopedic standpoint. And one of the things that I'll tell patients when they come in, someone's having a lot of knee pain, say, and they're clearly obese, they're well overweight. And I'll tell them, probably the single most important thing you can do is to lose weight. That's going to have a bigger impact on you than anything else I'm going to tell you, bigger than changing your shoes or doing some physical therapy or improving your flexibility. It's losing weight. And so it's something that I think, doctors across the board deal with, but certainly I see it and deal with it, on a daily basis. And,
which is important for people that are watching this show to understand that, weight control and nutrition, regardless of what specialty or what part of the body, whether it's a musculoskeletal problem, an internal visceral issue, other physiological problems, mental capacity, it all, physical fitness, being healthy, staying active is kind of critical step one for keeping our kids in good physical health. So that's good. So what things as a pediatrician, early on, are you looking for that an orthopedic pediatrician may have to, for hip issues, hip dysplasia? I know people hear about these things, scoliosis. At what point are you evaluating these things? Sure. And then what are some of the effects, when you have to refer them to someone like Dr. Benjamin?
So hip dysplasia, it's used to be considered congenital hip dysplasia, whether you were born with it. We now know that it's more of a developmental hip dysplasia. So we are constantly monitoring babies throughout infancy for any sort of laxity or dislocatability of their hips. And that's part of a routine exam when the babies come in pretty much every time throughout the first year of life.
So when you click in the hips, and my parents like, that's what we're looking for.
Exactly. You know, we're rotating them. They're kind of looking at us like, why are you trying to pop it? I said, well, I'm trying to pop it out, and I hope I can't, you know.
Exactly.
So, so that's actually really important. And if we do feel like there's any sort of, you know, abnormality of the exam, it is so important that these things are picked up early, because intervention solves the problem.
Right.
So, you know, as soon as we feel that there's something that seems to be abnormal, we're not quite sure, maybe, you know, there's something that feels, if it's an obvious dislocatable hip, or if there's a hip that, you know what, it feels a little loose, we're not sure, we're going to refer it to the pediatric orthopedist.
Right. And then what would be a treatment protocol for something like that?
So I see lots of patients referred for hip dysplasia. And you know, sometimes it's very mild and it's just a matter of observation and they resolve spontaneously. That's not unusual. But for the child who really has a dysplastic hip, and the discussion I usually have with families is that the hip is a ball and socket joint basically, and the problem generally is that the shape of the socket is not full enough. It's too flat. It doesn't sort of contain the ball the way you would like it to, and the ball is often not centered perfectly inside that socket. So what you need to do if they require treatment is something called a Pavlik harness, which is a harness that holds their hips and legs basically in a frog position. So their hips are flexed up and abducted out to the side. So it looks a little funny, but it's pretty easy to manage. They can still put them in their car seats and breastfeed.
I have pictures of my sister, and I used to use it against her, but as I got older and more mature, I don't use it against her. But I understand it is a bit of a harness. You got to stand in a certain position and everything.
Exactly. So the harness holds the hip in so the hip can grow and develop into a normal position.
And it resolves the problem. So it's something that parents that wouldn't know what it is may be concerned, but it's typically something that can be resolved, that usually can
most of the
be
time,
handled and everything.
But if you don't look for it, it's often silent. So if you're not looking for it, it cannot be picked up.
That's the importance of the continual evaluation. Because if you do miss it, then it can get more complicated.
Absolutely.
Because then you have different issues with the femoral head. So, okay, so that's one topic. Scoliosis is probably another one that we deal with, from adolescence all the way to young adult and into adulthood. And at what point do we start looking at those issues from a pediatric perspective, and then have to maybe refer on to pediatric orthopedics?
Well, so the common scoliosis, idiopathic adolescent scoliosis, we really are screening for generally as just before the start of puberty. But we've learned that scoliosis can be across the board, and kids can actually develop scoliosis at a very young age. They can have congenital scoliosis. So that tends to be part of a normal exam anyway, is doing a back exam. We're paying particular attention, though, during adolescence when there's a period of rapid growth, because that's when you can have the most rapid potential for change.
Right.
So we will, at all of our physical exams, we'll measure the patients with scoliometers. It's a little level that you place on the back, and we look at them from different directions and try and get a sense, if there's any sort of an abnormality. And generally, my threshold for referring out for an evaluation really does depend on the child's age. If it's a kid who has a lot of potential growth, who's pretty early on in puberty, I'm going to have a little bit of a lower threshold for referring, because I know that there's more potential for change.
Sure.
Someone who's kind of toward the end, where we're seeing a little bit of an asymmetry, well, it's probably okay for us to continue to follow. So,
are there any misconceptions heavy backpacks are causing scoliosis, or any of these other things?
I see that all the time. Scoliosis is a major part of my practice, probably about half of it. And when I see a child, and again, the most common patient is an adolescent girl, certainly, and they'll always ask, should they not wear a backpack? Should they switch it? Or different things like that. And there's no question that backpacks do not cause scoliosis, and they don't. If you have it, they don't cause it to get worse.
It could cause general back pain, it could cause other issues, but not scoliosis per se.
There's good evidence, backpacks over 15% of body weight will cause back pain, but not deformity, not a fixed deformity.
So how do you manage your cases? Are they trying to conservatively manage them, rehabilitation, physical therapy, different exercise methods?
Lots of different ways to do this, and as Kristin intimated, there's really a huge gamut of scoliosis. So the easiest part to talk about is the idiopathic scoliosis. Those are the otherwise normal children who are typically in the adolescent age group, although there is a population of younger children who develop it as well. And we have, where I work at Columbia, we have a big sort of conservative spine center where we look at lots of non-surgical interventions to try to help prevent the progression of scoliosis. And the two most important interventions are bracing, which has been shown to be effective. There's actually a very recent study that came out about 2 years ago that for the first time really proved that bracing can help prevent progression of scoliosis. And we also do use some scoliosis-specific therapy, something called Schroth physical therapy, which is something that has been around for 100 years or so, but really only has gained a toehold in this country more recently. And it's
become a more mainstream.
It has. I think it really has. And people, I get more and more people that are coming to me who know about it and are asking about it. It is something where there is some evidence behind it showing that it can be effective in halting progression. And I even have patients who have made their curves get significantly better through doing the physical therapy. So it can be challenging because there's not a lot of therapists that are certified in doing the Schroth method. But it's definitely something we use a lot of.
As you educated us, because now we're actually looking at getting our physical therapists certified in that technique because we were interested in it as a preventative and conservative measure. So we were doing our research.
Right. No, it would be great. We're always they'll be busy.
Yeah, absolutely. So I mean, because surgery at adolescence, for scoliosis is something that you want to try and avoid, if possible, but you do have to be worried about like other significant effects or visceral effects if the curves are getting too severe, and that those are rare cases, hopefully, but that's things
I mean, it's an interesting discussion that we have because there is some debate about what are the really long-term effects of idiopathic scoliosis. I mean, certainly, for the indication for surgery is generally a curve that's so big that we know it's just going to continue to get worse throughout life, and
there's a psychological component with some of the girls, and maybe
that's a major
physique
part of it.
And how they look, and that's probably things that you're dealing with in your practice as well. So
absolutely, it plays a big role, especially during the teen years when it's really important to not be different.
Yeah. So I want to talk about you guys just based on the community for a little bit, because you guys are you grew up in Pleasantville, and you both are raising a family here. How is it being here, being professional doctors, and I know you work with the high school as the school physician, and just being involved with the community, how do you enjoy that as a professional?
I think it's a great experience, actually. It's really nice kind of getting to know my patients from both sides. It's kind of funny sometimes when you see someone in the supermarket and they kind of look at you like, wait, you're not supposed to be out of the office. But having kids in all three of Pleasantville schools, it really is. It's a really neat experience to be able to kind of participate in the community as well as kind of be able to give advice. And acting as a school physician has been a great opportunity for me to really kind of help to kind of guide the school as far as their healthcare policies and really make sure that everyone, including my children, is living in a safe place.
And yourself?
Yeah, no, I from being a physician in the community and having a father who was a physician in the community, before that, starting in 1980, it is great because I love being able to share and help people, and we have people in the kitchen, once a week, somebody who's, I hurt my knee at the game. Can I, what should I do? I was like, come over, we'll take a look at you. And so that happens all the time. I get calls and texts constantly, which I love because I love, it's what we do. We help people.
And once in a while, you guys say, hey, we're going to go out of town tonight. But sometimes, for the most part, it's a good experience.
It is
now,
a good experience.
Being with the high school, have you seen different trends in sports-related injuries through the high school over the years, and concussions being a big topic now?
For sure.
What's any concerns in that regard? Or is it just being more diagnosed because they've set the thresholds a little bit, lower to make sure that they are diagnosed and not missed? So what do you think about?
So concussions, I mean, it almost seems like there's more of an epidemic of concussions. So many people are getting concussions, and parents are saying, well,
some specialists would say there is an epidemic, but not quite an epidemic. So it's like,
and you'll get the attitude, well, I wasn't, I had concussions as a kid. I wasn't pulled out. I was fine. But what used to be referred to as a ding or you got your bell rung was really, it's a concussion is a brain injury.
Yes.
And we don't necessarily say that to parents, that your child has a traumatic brain injury.
That sounds scary.
It sounds scarier, and people think, well, concussion, it can't be that bad. But I think, one of the reasons is, kids are doing sports at a younger age. So we've got more kids out there, which is good, because that goes back to the whole obesity. We want kids to be out and be active. But on the other vein, also, we all have a heightened awareness, and we're looking for them. We have more reporting for concussions, and we're taking them more seriously. And we're realizing they really do have long-term effects.
Yeah, and then, just cervical injuries, other types of, head-on injuries, whiplash injuries, whether it's basketball or football or soccer, cervical fractures could be scary, clavicle fractures, other types of musculoskeletal issues. And, managing the kid and the child and the parents is kind of like a team effort. And I think that's the one thing that, as community members, all professionals, we're doing a better job, and we're trying to always do a better job of keeping the line of communications open between the healthcare professionals, from the school nurse to the school physician to the athletic trainer to the orthopedic surgeon, making sure that the families have kind of a game plan. And that's the one thing. Everyone's like, well, okay, Johnny just got hurt, but no one knows who to make the first phone call, and they end up in the first emergency room, and then they get kind of, moved around. So it's just a matter of managing those cases and making sure everyone's on page. So, and what other trends are you seeing in your practice?
Certainly from a sports medical standpoint, ACL tears, which have been a major issue, and the incidence has certainly been rising, in recent years.
And girls soccer is supposedly
there's girls soccer teams where half the kids have had their ACLs reconstructed, and there's no question that girls are more prone to it, and there's a lot of more research kind of looking into why, and there's a lot of sort of biomechanical reasons. It's sort of the way that they jump and they land that likely puts them at significantly increased risk. And there's actually good evidence showing that doing very specific neuromuscular training can reduce the risk of ACL tears. So just kind of teaching them how to jump in a different way.
Right.
So that's certainly a major trend as far as what you see in kind of pediatric orthopedics. The other thing that we see a lot of and get referred to, and sort of more in the younger kids is again, it's really just kind of going back to hip dysplasia. I think that we do see a lot of referrals for hip dysplasia, just because there's a lot of concern for it amongst the parents and the pediatricians.
Prevention, making sure it's caught early, and even if there's a question, and you need a second opinion, that's why we have specialists, and that's why we communicate amongst professionals to make sure that we don't miss these opportunities. So
I think a lot of what both of us do is reassurance. You see a child who's probably basically okay, but it's it's either a first-time parent, which are usually pretty easy to pick out, or just an otherwise anxious parent or anxious grandparent who wants to be sure that that the child is okay.
And you touched on prevention a little bit and training, and you hear it all the time, but you wonder how much these kids are doing it and what ages they should be doing it. There's a lot of different schools of thought of when they should start lifting weights, when they shouldn't be lifting weights, what's too early, what's too late. But even just functional training, basic, what we used to call calisthenics, kids aren't doing as much, I don't think, and they're not as active as they used to be. And I wonder how much that plays a role in. I get concerned with the iPads. The shoulders and the necks and just the back pain and headaches alone, just from poor posture. As a chiropractor, I look at those things. I'm like, that's a long-term problem if that kid doesn't learn to, sit themselves up straight and work on their back. So I feel like their bodies aren't prepared, and yet they're doing more, but they're preparing less in some ways. Right. I don't know. What do you think?
Right. It's funny. I kind of talk to my teens about that. When they're really intense with their sports for one season, and then they have nothing the next season. I said, well, what are you going to do in between? Well, I'm not going to do anything. It's winter. I said, well, you don't want. We almost compare it to like yo-yo dieting. Like you're going to be full on tense and then 0 and then 100%. I said, when you go from 0 to 100%, that's when you're more likely to have your injuries.
Yeah. And I think there was a trend. Just speaking to the ATC here in town, he said, these kids showed up in August. They hadn't done much before August, and kids they're winded. They're getting heat stroke. They're getting all these different things. So. How do you feel about the whole prevention?
No, I think, I mean, there's no question about that, when kids go, like in August is just classic because they have summer off, they're not doing very much and they're not doing the work beforehand, and there's definitely an increase in injuries. And injury prevention, of course, is huge. I mean, I think it's very important, and when done properly, can be very effective.
Very effective, yes.
And there's no question. I mean, you have to pick your population, like you said. I mean, you don't need to have 8-year-olds doing,
deadlifts and squats.
Well, absolutely. But even like the sort of, 8-year-olds don't pull their hamstrings, right? That's just not something. But you need to instill those behaviors and those lessons earlier in life. So the 8-year-olds and 9-year-olds, they're doing warming up and they're stretching before their soccer games, and it may be a little not, it looks a little bit funny and cute, but by getting used to doing that, and then they continue to carry that through, can really be helpful in it. So there's that part of it, just kind of the proper warming up and getting ready. I mean, there's other types of preventative programs, like how do we prevent ankle injuries in basketball players, right? And so maybe just putting some functional ankle braces on them, lace-up ankle braces, that can help prevent that. And the neuromuscular reeducation, as I said, for the ACL tears, and these are things that schools can sometimes embrace and incorporate as part of their curriculum for their field sports.
This is low-tech stuff they could be doing. Easy, this is not like you use physio balls, wobble boards, very low-tech. You don't need a huge gym. You don't need to go join a big fitness club. You could do this stuff like literally on your driveway if you're trained properly. Functional movement systems and things of that nature. I think going back to the fitness, the obesity, the nutrition, the prevention, making the kids active. I mean, they all need their downtime, but they also need to be prepared for their busy times and everything.
Right.
So,
but I think also coaches need to recognize that too, that they are kids, and they're not necessarily motivated adults. So a lot of them are not going to do anything over the summer, and kids are going to be kids. So to get in there and to try and kill them right away, in preseason and whatnot, sometimes you have to reevaluate, and there needs to be a little bit more of a gradual introduction.
Yeah. So, from a pediatric perspective, like I said, your days may be completely different, right? But at the same time, there's a lot of crossover in your specialties and working with children and educating, families and keeping. Are there any major changes in pediatrics that are forthcoming that you see in terms of any big surprises coming up, or everything's about the same? Yeah.
Not much. I mean, with some very sort of specialized things.
Maybe for surgical.
For early onsets for scoliosis. So for children who are very young, like less than 8, who have really severe curves. We've recognized for the past 15 or 20 years that you need to have some sort of a growth-sparing intervention. And so we've had these what are called growing rods that you put in that sort of, a strut that supports their back, but they need to be lengthened as the child grows every 6 months. That's a lot of surgeries.
Yes.
So actually just last year, in this country, finally approved a magnetic growing rod, which is great. So we can implant the rod in one surgery, and I can lengthen it in the office just by putting a magnet on their back, and that lengthens this rod, and so it preserves their spine growth so they can get bigger until they're big enough that we can do a more definitive fusion procedure. So that's sort of a real revolutionary change in the way that we approach these kids.
Yeah, I think with all medicine, there's always new emerging technologies, and I think it's great to know what those are. So I'm going to ask you both. So who takes care of the kids at home? Who doctors quicker? Who goes faster when the kid goes down? You have some kids playing sports.
It's probably more like, you're fine. I've seen worse.
Exactly.
That is exactly what happens, and it's hard to be a kid in our household because they can't get away with anything. Right? You can't fake an medical illness, and you can't fake an injury because you have someone who's going to got it covered.
That's great. Well, look, I want to thank both of you for being here tonight. I think it was a great show. Both of you are welcome to come back because your specialties in their own could be just a show in themselves because there's so much really information and topics to talk about. But I think we covered a lot of good information for the parents and for people that are watching. And you guys are doing great community work. I know you work with the Community Scholarship Fund and Pleasantville Day and some other things. And you guys are all always out and about in town. So we appreciate your community efforts and your professional work. So thank you very much.
Thanks for having us.
Thanks for having us.
Bye-bye.
Thanks.
Thank you for watching Health IQ, and we look forward to seeing you at our next show. Thank you. Bye-bye.